Picture this. You're in church choir. Maybe you've been singing soprano for 20 years and you notice the high notes getting harder. Not impossible, just harder. You're running out of breath more quickly. Your voice feels tired after rehearsal in a way it didn't used to. And there's this breathiness you can't quite shake. Or maybe you're a voice teacher with a student in her 60s who's been with you for years, and you're watching her range shrink. She's frustrated. You're frustrated. And neither of you knows if there's actually something you can do about it. Look, I'm going to level with you right up front. This episode is dense. We're talking about aging, physiology, and what happens to your voice over time, which is not exactly light viewing. Aging is not for the faint of heart. But stick with me because research here is actually really hopeful. There's some solid evidence for interventions that work. Real improvements are possible. So, if you're ready for some voice science that might feel a bit like drinking from a fire hose, but comes with genuinely good news at the end, let's do this. Age-related voice changes are real. They're common, and they're not in your head. But they're also not inevitable in the way most people think. In this episode, we're going to talk about what actually happens to the voice as we age, the real physiology, and, more importantly, what you can actually do about it. Because the research shows that about 85% of older adults who get appropriate voice therapy see meaningful improvement. So if you're an older singer wondering if your voice can get better, a teacher working with aging students, or a choir director managing an ensemble where average age keeps climbing, this one's for you. What actually happens to aging voices? The technical term is presbyphonia, from the Greek presbys, meaning elder, and phonia, meaning voice. And the numbers are striking. Structural changes show up in about 85% of adults over 74 when examined with a laryngoscopy. But these changes start much earlier than 74. Research shows structural changes beginning to appear in significant numbers of adults in their 40s and 50s, with prevalence increasing substantially with each decade. Now, there's an important distinction here. Presbylaryngus refers to the structural changes you can see on examination, while presbyphonia refers to the actual voice symptoms that bother people. About 85% of older adults show the structural changes, but only 10 to 20% report voice problems that actually impair their quality of life enough to seek help. That gap matters. It means structural aging doesn't automatically equal function problems. But what's actually changing? Quick aside, I'm about to go fairly deep into the physiology here, and I know that it's not everyone's favorite part. But understanding what's actually happening helps you understand why certain interventions work and why others don't. It's the difference between someone telling you to do this exercise and actually knowing why that exercise targets the problem. If you want to skip ahead to all the practical stuff, there are timestamps in the description. But if you're sticking with me through the next few minutes, understanding the physiology will make everything else make more sense. Vocal fold muscle atrophy. The thyroid muscle, the body of your vocal fold, loses mass as you age, just like every other muscle in your body. This is sarcopenia, the same age-related muscle loss affecting your arms, legs, and core. Research using electron microscopy shows muscle fiber diameter decreasing from about 16.4 micrometers in middle age to 14.2 micrometers after age 76. A statistically significant shrinkage of the individual muscle fibers themselves. When the muscle loses bulk, it can't maintain the shape and tension it used to. This creates vocal fold bowing. The edges develop a concave curve instead of coming together cleanly, like a warped door that won't close all the way. That gap means air escapes when you phonate, which you hear as breathiness and feel as loss of power. The medical term is glottal insufficiency, Your glottis, the space between your vocal folds, doesn't close completely during phonation. The extracellular matrix, the tissue structure between muscle fibers, deteriorates. This is where things get particularly interesting. Hyaluronic acid, which keeps vocal folds pliable and lubricated, decreases as the body reduces production. At the same time, collagen accumulates, but not in a helpful way. Young vocal folds have collagen organized in what researchers describe as a wicker basket pattern, providing structure while maintaining flexibility. Aging vocal folds develop disorganized collagen bundles that create stiffness rather than support. Elastin, the protein that provides snapback quality and helps vocal folds return to position after vibration, also declines. The net result? Your vocal folds become measurably stiffer and less elastic. They don't vibrate as efficiently, and the voice quality suffers. The laryngeal cartilages calcify and the joints degenerate. The cricoarytenoid joint, which rotates and slides the arytenoid cartilages to adjust vocal fold position and tension, essentially develops arthritis. Studies document narrowing of the joint space, irregular surfaces, and reduced range of motion. The cricoid and the thyroid cartilages themselves calcify, losing flexibility. When you can't adjust the length, tension, and mass of your vocal folds as precisely as you used to, you lose range, especially at the extremes, and register transitions become more difficult. The mechanism for adjusting from thyroarytenoid dominant to cricothyroid dominant function becomes less responsive. Respiratory system decline compounds laryngeal problems. Lung capacity and vital capacity both decrease with age. The intercostal muscles and diaphragm weaken. Lung tissue loses elasticity. The same process affecting your vocal folds is happening in your lungs. The chest wall stiffens. Any postural changes, like a forward-leaning posture, further restrict the rib cage's ability to expand. The result is a cascade. You've got less total air volume, less ability to generate subglottic pressure, and less endurance for sustained phrases. Your larynx is trying to function with reduced fuel supply. Even if your vocal folds were working perfectly, the respiratory system can't support them the way it used to. Hormonal changes create sex-specific effects. For women, postmenopausal changes mean decreased estrogen and relatively increased androgens. This causes vocal fold thickening, increased mass, and edema. Tissue swelling. Research documents voices lowering by an average of 35 to 39 Hz after menopause, which is substantial. A voice that was 200 Hz premenopause might drop to 165 Hz. That's nearly 3 semitones. Women often describe their voices feeling heavier or thicker. For men, decreased testosterone causes slight vocal fold thinning, though the perceptual effects are far less dramatic and noticeable than in women. The voices of men and women actually converge somewhat in advanced age as hormonal profiles become more similar. These changes don't happen in isolation. They compound each other. Muscle atrophy creates bowing, which causes air escape, which triggers compensatory pushing, which increases vocal fatigue, which leads to avoiding vocal use, which accelerates atrophy. It's a cycle, and that's why early intervention matters. How this actually affects your singing. So what does all this mean when you're actually trying to sing? You lose range, especially at the top. Sopranos who once reached high C find their comfortable upper limit dropping. Your voice gets breathy. You can't quite get clean vocal fold closure. There's air in the sound even when you're trying for a clear tone. Maximum phonation time decreases. Phrases you used to sing easily now require an extra breath. Legato passages feel choppy. Vocal quality changes in ways listeners can hear. Increased jitter, pitch wobbles, shimmer, volume wobbles, shakiness, irregular vibrato. You can't sing as loudly. Dynamic range shrinks. Vocal endurance tanks. Your voice tires during rehearsals that used to feel manageable. And when you're faced with incomplete vocal fold closure and air escape, about 94% of people develop compensatory muscle tension. You start squeezing, pushing, recruiting extraneous muscles trying to force the sound out. This makes everything worse. You're working harder, tiring faster, and getting a pressed, harsh sound instead of a free, resonant tone. I haven't experienced this personally yet. I'm in my 30s. But I've worked with enough older singers to see how frustrating this is. Your voice is tied to your identity if you've been singing your whole life, which is why what comes next matters. Vocal function exercises, the intervention with the strongest evidence. There's a set of exercises with really solid evidence, vocal function exercises, or VFE. Multiple randomized control trials, significant improvements across multiple outcome measures, and it's accessible. You can practice at home once you learn the protocol. Developed by Dr. Joseph Stemple, VFE applies exercise science principles, overload, resistance, progressive challenge, to voice production, strengthening intrinsic laryngeal muscles and improving coordination. The protocol consists of 4 specific exercises. Exercise 1. Sustain the E vowel, E, for as long as possible at a comfortable pitch with extreme forward focus and nasal resonance. Exercise 2. Glide smoothly from your lowest comfortable pitch to your highest on the word null, all in one breath, with an inverted megaphone mouth shape, expanded pharynx, narrow lips. Exercise 3. Same glide in reverse, highest to lowest on null. Exercise 4. The power exercise. Sustain 5 ascending pitches, holding each as long as possible on null, with semi-occluded posture. The specific pitches by voice type: soprano, C4, middle C, D4, E4, F4, G4. Mezzo alto, B3, C4, D4, E4, F4. Tenor, E3, F sharp 3, G sharp 3, A3, B3. And finally, baritone and bass, C3, D3, E3, F3, and G3. The dosage. Each exercise twice, 2 times daily, for 6 to 12 weeks. Volume is soft as possible, while maintaining clear and consistent tone. The research shows impressive results. In the original 1994 double-blind placebo-controlled trial, participants showed significant improvements in phonation volume, airflow, maximum phonation time, and frequency range. Multiple studies in older adults with presbyphonia have replicated these findings. Studies show continuous improvement in maximum phonation time across 12 weeks, decreased glottal airflow, better closure, increased subglottic pressure, better breath support, and significant reductions in voice handicap index scores. Quality of life improvement. The critical findings across studies include Functional improvements often occur even without changes in vocal structure. The bowing persists, but the voice works better. Muscle function improves through strength training, even when anatomical bowing remains visible. A systematic review of 21 studies found moderate to strong effects for patients' self-reporting measures, the outcomes that matter most to quality of life. About 85% of patients seeking treatment see meaningful improvement. Now, this takes work. Twice daily practice for 6 to 12 weeks is a commitment, but it's effective. Other evidence-based approaches. Vocal function exercises aren't the only option. Phonation resistance training exercises take the opposite approach. High-intensity vocal exercise at 80 to 90 decibels instead of soft phonation. Randomized trials show significant improvements in quality of life and reduced effort, sometimes exceeding VFE outcomes. Adding respiratory muscle strength training, using devices that create breathing resistance, may produce even better results when combined with voice exercises. Semi-occluded vocal tract exercises like lip trills, straw phonation, and humming can be helpful additions under the care of a speech-language pathologist. Though, note they may cause hyperadduction of the true vocal folds in some cases, so professional guidance is important. I should mention briefly that surgical options exist. Injection of material into the vocal folds to restore bulk, but voice therapy is typically first-line treatment, and that's a medical decision requiring specialist consultation. We're not going deep into surgical options here. The point? There are multiple evidence-based interventions, and voice therapy works really well for most people. Practical advice for singers and teachers. For aging singers, and let's be clear, this is a when, not an if situation. Anyone of advancing age experiences effects. Get professional assessment. Hoarseness lasting more than 2 to 3 weeks, significant vocal fatigue, pain when phonating, or sudden dramatic changes warrant evaluation by a laryngologist. Work with a speech-language pathologist who specializes in singing to learn vocal function exercises. The Voci Academy vocal function exercise tool can guide you through the exercises, but ideally you want at least initial professional supervision from an SLP or a voice teacher to ensure proper technique. Maintain daily vocal practice. Sing 15 minutes every day, even if only exercises. Work all registers each session: thyroid retinoid dominant, chest voice, and cricothyroid dominant production, head voice. Observational evidence shows that singers who stay vocally active maintain abilities longer than non-singers. So, keep singing. Prioritize cricothyroid dominant, head voice development. This register becomes harder to access as the larynx positions lower with age, and hormonal changes in women create vocal fold thickening that limits cricothyroid muscle access. Address lifestyle factors. Don't smoke, the most damaging factor. Maintain hydration. Engage in regular exercise. Manage reflux and thyroid issues. Set realistic expectations. You'll likely lose some upper range. Your vocal agility will decrease, and overall power will be reduced. But severity varies dramatically. With appropriate intervention, maintaining or significantly improving is possible. For voice teachers, learn to recognize presbyphonic changes and become proficient with vocal function exercises. Recommend that students seek out a speech-language pathologist early and often when signs appear. Early intervention is key. Adapt lesson structure. 15 to 20 minutes of actual singing with frequent rest breaks. Prioritize daily practice over duration. 15 minutes daily beats infrequent longer sessions. Modify exercise selection for aging voices. Use descending patterns before ascending, starting mid to low range. Work on cricothyroid dominant function regularly. Select repertoire based on comfortable range more than range extremes, with shorter manageable phrase lengths. Transposition is always an option. Healthy production matters more than published pitch. Provide psychological support alongside technical training. Voice changes are intimately tied to identity. For choir directors, structure your rehearsal exercises thoughtfully. Breath awareness first, then gentle onsets and semi-occluded exercises, then resonance work, then gentle pitch work, finally, articulation. Avoid pushing for extremes early. Reconsider section placement as voices age. Women's pitch lowers. Sopranos often transition to altos. Test tessituras rather than forcing traditional assignments. Select repertoire with moderate ranges, shorter phrases, and clearer textures. Transpose keys freely. Folk songs, spirituals, show tunes, gospel, and selected sacred works often work well. Create a culture where resting one's voice when needed is acceptable, not shameful. The bottom line: presbyphonia is real, common, and creates functional limitations. But it's also very treatable. About 85% of older adults who get appropriate voice therapy see meaningful improvement. Not just maintenance, but actual improvements in quality, reduced effort, and better breath control. Vocal function exercises have strong evidence from multiple randomized control trials. Treatment requires commitment, 10 to 15 minutes twice daily for 6 to 12 weeks. But compared to progressive decline, that's manageable. While we can't fully prevent vocal aging, we can substantially mitigate its functional impact through evidence-based interventions, enabling continued singing participation well into advanced age. If you're experiencing vocal changes, don't accept, "Well, you're getting older," as the final answer. Seek professional assessment. Use evidence-based interventions. Check out the Voci Academy VFE tool, link in the description, to get started with guided practice. Voci Academy runs bi-weekly live Q&A sessions where you can ask questions about vocal health, technique, and working with aging voices. We're focused on evidence-based approaches to efficient singing. As always, keep singing smart.